हाँ अभी तक क्लियर हो गया? टीयर 2 में क्यों आ गया हम लोग? This is hyperventilation. But what is the other thing you would like to do to reduce the blood volume is to actually cause more amount of improvement is deeper sedation. Deeper sedation. Okay, I'm going to go into much deeper sedation that I was otherwise think of. So here I was RASS -1 to -2. Here I'm going to -3 to -4. I never want to wake up my patient now. Now I'm in a situation where I don't want to wake up my patient. समझ में आ रहा है? हाँ, it is getting worse. अभी उसको wake up ही नहीं करना मुझे. So -1 -2 में patient फिर भी उठ जाएगा. 0 to -1 में तो उठेगा, ऐसे बात करते उठेगा. हाँ, but now I want my patient to never wake up only. हाँ, till the ICP gets under control. So now I'll go from -1 -2 to -3 -4, deeper level of sedation. You understand? And that is the problem. How to assess deeper? Is how to assess deeper. So ideally, patient should never wake up. Patient should never cough on the tube. Patient should never trigger the ventilator. That's the level of deepness you require. Okay, it's like anesthesia. At this time, it's like anesthesia. Okay. So when you're in tier 2, you're almost like anesthesia. So tier 1, you to make you understand again. Tier 2 is once you go from tier 1 to tier 2. In tier 2, what am I doing? I'm going to change carbon dioxide. Till now I was not doing that. Huh? Till now. Number. So now we are at tier 2, correct? Where?
2 hyperventilating.
We are hyperventilating.
And we're going deeper sedation.
But we are keeping the hyperventilation between ETCO2 of
Now it's 33, 24. No, it
Is
is 26 to 30. 26 to 30.
It's 26 to 30. This is where I'm keeping it. I'm not keeping it. And for that I require paralysis. I can't do without paralysis because if patient triggers the ventilator, it will become very difficult for me. I may require paralysis here. Now I move from one step higher. I move from what I was to one step higher. You're understanding how it's going? How it's going? Step 2. In this field, in this where I'm actually reducing volume, will be my tier 1 also, which is external ventricular drain. Reducing volume, na? You understand? So the EVD will come here. When I say EVD, na, it will come here. External ventricular drain. समझ में आ रहा है? Clear? On tier 1 because I'm reducing volume. That's why you can remember. If you remember it like this, na, it's easier. Tier 1, tier 2, tier 3 because it comes in exams. This is tier 1 therapy or tier 2 therapy or tier 3 therapy. Clear? So I'm reducing volume, so I put in EVD and I remove the CSF, it becomes tier 1. ठीक है? Clear? Tier 2 हो गया? Tier 2 is clear? Now tier 3 comes. Okay. Now what is tier 3? Here you have reduced, here you have prevent worsening, tier 0. Tier 1, you have actually tried to remove volume a little bit by osmotherapy, volume. And tier 2 is when I'm actually trying to remove, alter the blood somehow. I'm trying to alter the blood inside the system somehow. Then comes tier 3. What is tier 3?
Last resort.
What is it?
The burst suppression.
What is it? So what am I doing? So if I were to put it like this, like worsening, blood, volume and blood, what is this?
Last resort.
Brain activity.
Shut down. Shut down. Okay. Shut down. That's what it is. It is shut down. Okay. I don't want the brain to bloody function only. I want it to rest. Shut down. Okay. That's what we do when you have a computer, right? If a computer is going haywire, you shut it down. You shut it down and then you restart it. Correct? So this similarly in the brain, you shut it down. Okay. And to shut it down, there are two things. Either you shut it down or you remove. So the decompression comes there. You shut it down or you remove. Okay, so to shut it down, I need to go to burst suppression. So very often what happens in private practice, in practice if you're working doing ICP and doing all of these things, you realize that there's a very thin line between tier 2 and tier 3. Very often the propofol itself causes burst suppression. When you're at -3, -4, you're already in burst suppression. Very often it happens that way. Very often you see tier 3, tier 4 में already tier 2 में आ गए तुम लोग लेकिन burst suppression चालू हो गया. But what is in my mind? I have moved from tier 1 to tier 2. I have moved from tier 2 to tier 3. My prognosis is worsening. My prognosis is worsening. Getting the point? My risk of therapy is going even more higher. My risk of therapy is going even more higher. समझ में आ रहा है? ठीक है? Clear on this? My risk of therapy is going even more higher. This is what I initially explained to you all. As I'm going ahead, my risk of therapy is going even more higher. Clear? Clear on this? No? So burst suppression when it comes, classically burst suppression is done by barbiturate. Classically. Burst suppression done by barbiturate. But as I'm telling you, you may not require that barbiturate because when you are on very high dose of propofol, you might be already on burst suppression. Huh? समझ में आ रहा है? हाँ? So tier 1 हो गया, tier 2 हो गया, and then the last thing comes. The last thing comes which is decompression. In the same tier 3 में you have decompression, removal. That means I want to remove the brain, I want to remove the pressure completely. So I decompress the brain. I decompress. Removal आ गया इसमें. ठीक है? So I am decompressing my brain. That is tier 3 management. So if I move from tier 1 to tier 2, I should be ready to start decompressing my brain. I'm in that zone now. I'm in that zone where decompression may be required. You getting the point? I'm in that zone where the decompression may be required in order to release pressure. But I know very well that if I move from tier 1 to tier 2 to tier 3 in an emergency, the prognosis of this patient is worsening. The overall outcomes are bad. If I move.
That's when I have a question. Then is burst suppression really worth it to do?
Yeah, it is. Prognosis is bad. That doesn't mean that that person cannot be kept alive. That person cannot. You never know what's going to happen. Correct? Brain is so plastic. There is something called plasticity in the brain. So we don't know what happens to what patient. You have to keep him alive. If one of the fields in medicine which has a huge nihilistic attitude is brain. When I say nihilistic attitude means अरे क्या है वैसे भी वो उसका जिंदगी खराब रहने वाला है. That is an attitude that people have when it comes to brain. क्या quality of life होने वाला है. But that's a fine balance. That person's husband, that person's wife, that person's son and grandchild may want it still. I want it that way. That's fine. That's a perception. Okay, that's a perception. You cannot decide somebody else's journey, but as a doctor, you have to inform that this is what the situation is. The reason, sir, isn't flexible patient, huh? So, so you understand what I'm saying?
What is the thin line between tier 2 and decompression? Like, what is the thin line? Like, we are supposed to take a decision for decompression. Like, we are on tier 2.
No, that's correct. So there's no thin line here. तुम्हारा ICP कभी नहीं हो रहा है, कुछ नहीं कर सकता ICP है तुम्हारे पास. तुम्हारा ICP कम नहीं हो रहा है. You are still, I mean, you take it fast this way. You have a patient who comes with traumatic brain injury. You have done everything possible. Pupils are still dilated. One side is dilated, one is not reacting. ठीक है? हाँ, तुमने उसको मैनिटॉल दे दिया, हाइपोटेक्स दे दिया, तुमने उसको सेडेशन कर दिया, सेडेशन पे रख दिया. फिर भी उसका pupils वैसे का वैसी है. टियर 3 पे पहुंच गया, तुम उसको हाइपरवेंटिलेट कर दिया, 25 to 30 पे ला दिया, 27 पे ला दिया उसको. तुमने उसको डीपर सेडेशन पे ले लिया. He's gone to deeper sedation. Still the pupils are dilated. One pupil not reacting. Where do you go now? समझ में आ रहा है? But decompression. What about if the patient does not have any decompression का सामान ही नहीं है, उसके पास खाली generalized brain edema है? Then you might consider whether I want to burst suppress and then see. You understand? Burst suppress and then see. Decompression ठीक है, तुम्हारा EDH है, SDH है, वो सब ठीक है. Decompression that's fine. But you're not that. You're in that zone where there's nothing that you can probably achieve from that. Maybe I limit my burst suppression. So that's how it goes. So that's how it goes. Clear on this? Clear on this? So now in tier 4, in tier 3 you have come to burst suppression and removal.
Yeah.
ठीक है, burst suppression and removal, decompression, craniotomy. But now the prognosis is bad. The prognosis has come to that situation where it is bad and the risk of that decompression is very high. Decompression, it's no longer mannitol, it's no longer hyperventilation, it is decompression. So the risk has gone alarmingly high now. ठीक है? Huh? What have we missed out in all of these things? One thing that you correct. Where is that from? Huh?
Normothermia from tier 0 and then hypothermia from tier 2.
So right now, so in the BTF guidelines, they are mentioned that hypothermia is not recommended because it increases infection risk.
Correct. So that has gone out of the system now. Okay, it has become a strategy for a certain group. So in a tier management, you can't put it. Okay, in a tier management, you can't put it. So initially, how it was, how we used to do it. If you have reached tier 2, we start thinking of hypothermia. We used to use brain temperature monitoring and get the temperature down. All those things we used to do. Okay. Now no longer we are saying you to do this because the Eurotherm trial, which is a very large trial, which was done across many hospitals across many countries, actually proved the fact that it does not make a difference, rather it might cause harm. It might cause harm. So where do we use it then? You have to use it in specific population. Like for example, first of all, this means here when I say prevent worsening, I cannot give this patient when there is temperature, paracetamol. That is why it is not a PRN dose. It is a 4 times a day dose. When a patient is in trauma, when a patient you are suspecting raised ICP, it's not based on pain, it's not based on whether he has fever. It is directly given 4 times in a day. Clear on this? Paracetamol. You cannot have a single rise of temperature. If you had a single rise of temperature, you are causing worsening. That's why it comes in tier 0. That's why it comes in tier. It's a fundamental thing. It comes in tier 0. Fundamental thing. So you have a patient of raised ICP. Paracetamol should be written in the order, not SOS. 4 times in a day. We have to tackle it very urgently. And if by any chance the patient develops temperature, what will you do? But it is worsening. This means it's worsening. Unlike other patients, patient is developing temperature. You have put paracetamol 650 4 times a day. Avinash comes into the room. She comes for duty. 10 o'clock, morning time 10 o'clock. The temperature has gone to 100 degrees. What will you do?
Cooling fluids, cold fluids.
Cooling blankets.
How? So how do you do this? So what are the various ways you would do this? What have you understood now? If the temperature goes up, worsening. It's worsening. It is worsening. Even if he is not moving to tier 1, no, he's moved now.
Yeah.
If he is not moving to tier 1, he'll start moving. Okay, he'll move to tier 1. So what? Because I'm not going to say that he's worsening, so I'll give him mannitol. No, it's not like that. But he can go now into tier 1. Okay. So what do I do, Avinash? What will you do bedside? What is the orders you'll give?
Cold saline.
What? How? Why?
Normal saline.
What do you write on the sheet? Sheet में क्या लिखोगे? You are the bedside. You cannot at that time. You have to write something. You have to tell the nurse something. What will you write?
Paracetamol already.
Paracetamol already on. 650 4 times a day. It's not. If you have to give an order for paracetamol, you are done wrong in the first place. If you have to give an order of paracetamol to a patient of TBI, means तुम गलत ही हो, starting से गलत हो तुम. क्योंकि वो order पहले होना चाहिए उसके अंदर. Are you getting the point? So it's already there. Paracetamol is already there. Now what? So in short, in our hospital, when a patient of ICP comes in, 1 gram TDS paracetamol is on. You can make it 4 times a day if the liver is normal. 1 gram 4 times a day. It is on. Okay. So there is breakthrough. We probably may not. Paracetamol is not something you would think of. What?
Cold saline will you 500 ml bolus?
Means how? How do you do this?
There should be a particular temperature.
4 degrees.
Of the.
Correct.
Yeah.
So the order has to be very clear. The more time you wait with that temperature on the higher side, the more a problem. By doing intravascular cooling, is the fastest method to reduce temperature. Intravascular cooling is the fastest method to reduce temperature. So you have to do it right. So to do it right, it means the whole 500 ml, it cannot be 500 ml, it has to be 1 to 1.5 liters. You have huge amount of blood volume. You are cooling the blood. If you are cooling the blood, I can't give 500 ml. 500 ml से क्या घंटा कुछ होगा मेरे को? You understand? I need to ensure that the whole blood is cooled down by 1 degree at least. 1 to 2 degrees, correct? So that means I need the gradient first. I need the gradient. So the gradient has to be good enough. So the gradient has to be 4 degrees. That is from the fridge. It has to be from the fridge. Our temperature is 21-22 of our present IV fluids. Present IV fluids will be room temperature, which is 21 to 23 degrees in our ICU. That will be the temperature. Okay. If I am going to give that same one, it is cold only, but it is not adequate because the gradient is different. We want a very severe gradient. That's why from the fridge, the fluid has to come first. The second thing, it has to be given over 5 minutes. Very dangerous. Imagine you are giving 1.5 liters in 5 to 8 minutes.
Pressure bag.
Not only pressure bag, you are standing. You are not only pressure bag. Pressure bag में पहले जाएगा फिर वो slow हो जाएगा. Pressure bag से देखोगे तो it takes still 10 to 15 minutes. Is a pressure bag, it still takes 10 to 15 minutes. Okay, so if you are going to give without with a pressure bag, you are standing with the patient and pressing with the again pressing. समझ में आ रहा है? So that's why, and you're giving not one pint, you're giving 1.5 liters in 5 to 10 minutes. You're getting the point. So it can never be done without you standing besides there and doing it. And at the same time, you need a rectal thermometer. Now the problem with the rectal thermometer is it changes only once in 15 minutes. The problem with the rectal thermometer is it is not real time. You get the point? It is not real time. अभी जो टेम्परेचर आएगा वो चेंज होते हैं 15 मिनट के बाद. समझ में आ रहा है? So the rectal thermometer doesn't change every minute. Which is the temperature change every vascular temperature. So vascular temperature के लिए you need something like an SCVO to monitor, or you require one of those pico catheters. Actually, is vascular. We don't have vascular. The closest is esophageal. Esophageal temperature. Esophageal temperature is a probe that you put inside and you get closer core body temperature and much more reliable than the rectal thermometer. Clear? So you are in a very difficult situation. Correct? I can't go low because Eurotherm trial told me that if I go low, I'm going to cause infection and it might cause other problems. So I can't go lower. So that's why I don't use hypothermia. But to get to normothermia, I have to be very judicious and I have to be quick. You understand? So I will do oral temperature, I will do rectal thermometer to get that quickly down. So 1.5 liters. Clear? This is the order you will give. The order will be 1.5 liters of cold saline through a pressure bag given over 5 to 10 minutes. This is the order that you will write on the sheet.
Temperature was like specific.
40 from the fridge. You tell them from the fridge. From the fridge. There are fluid kept in the fridge. It has to come from the fridge. It has to come from the fridge. You can't tell them fluid though. Fast though. It doesn't. You have to be very particular. भाई ये टाइम पे जाओ. तो अगर इतना टाइम पे जाना है, you will write the order. You will stand there. No, where you will go anywhere. You will write the order and you will literally stand there. Because तुम जब तक तुम उधर खड़े हो तब तक वो जाना चाहिए. Are you getting the point? Clear on this cold saline. So tomorrow when you are actually having temperature for other purposes also, it has to be like this only. You can't give it slowly. For other purposes also, when you are doing this, you're supposed to do it like this. Now there are multiple benefits of doing that also. There are multiple benefits of doing that when you're giving that cold saline like that. When you give cold saline, now the entire body goes into vasoconstriction, which includes the brain. You understand? Since you are vasoconstricting there, you're vasoconstricting there also, ICP will actually come down. Are you getting the point? You're vasoconstricting there also, so the ICP can come down. You getting the point? Temperature itself lowering will cause the ICP to come down. Clear on this? That's why you cannot wait for it to reach 102 degrees. तुम 98 दिखा, तुम 99.5 दिखा, you give that saline. Don't wait for it 100 पहुंच गया, 101 पहुंच गया. So it's a non-negotiable thing in neuro. It's not negotiable. Today, if you have a patient who if you have a temperature on the screen showing 102 degrees in the chart, it is wrong. You have worsened the case. समझ में आ रहा है? You have worsened the case. It's not this way that you 102 अभी दिख. That is why continuous temperature monitoring. That is precisely the reason you need continuous temperature monitoring. समझ में आ रहा है? That's why rectal thermometer. You are getting the point? Getting the point? You can't monitor a patient with raised ICP without a rectal thermometer or some form of continuous temperature monitoring. Clear? So in the chart with 102 degrees, it is not advisable. It is not good. Clear on this? Clear? Any doubts?
He had mentioned something like esophageal cooling as well.
Yeah, so there are many cooling. I was in the Eurotherm trial when this trial was going on. So what was the trial? Or we have used it here also. In fact, for showing everybody, I had bought that here also. So there are various cooling devices. So if you're thinking of cooling is now gone so low in the cards that we aren't really doing it. But if you really want to know what are the various cooling things you do, first thing is intravascular cooling. First thing. The same intravascular cooling can be done by dialysis. Okay, if the patient has got a dialysis cannula in place, put him on dialysis and lower the temperature on the dialysis machine. Put him on dialysis and lower the temperature of the dialysis machine, so it will cool down. So if you have a patient of raised ICP and patient is already a CKD patient undergoing dialysis, put him on dialysis. Get the temperature down on the dialysis machine. समझ में आ रहा है? The third one is pleural cooling. That means they put ICD inside. They put ICD inside and flush in cold saline. So it happens now when you have a trauma that comes in, you may have an ICD in place. When a patient in trauma, you may have an ICD in place. So you should be thinking like this: कि अगर मेरे को ICD है, ventilator पे patient, let me cool the patient by giving pleural cooling. Like pleural cooling, just give fluid. 1 liter inside, 1 liter comes outside. 1 liter goes in, 1 liter comes outside. समझ में आ रहा है? Pleural cooling. Then the other thing is Other thing is intravascular cooling के अलावा cooling उसके बाद क्या है? Ray's tube cooling. So your Ray's tube 4 डिग्री जो टेम्परेचर देने वाले हो उसको 4-5 लीटर करो. 4-5 liters gastric sump. Okay, that means you put in 4 liters in, 4 liters out. Continuously on 4 liters in, 4 liters out. So that will actually cause cooling. Ray's tube. Okay, GI lavage, gastric lavage with cold salines, which actually reduces temperature of the body. Then you have this is all active cooling. This is called as active cooling. Okay. Then you have passive cooling. Passive cooling. Passive cooling में you what are other things? You'll remember. You'll remove the HME filter. HME filter is a heat and moisture exchanger. So you'll remove the HME filter from the circuit. Patient on the ventilator, you'll remove the heat and moisture exchanger because that holds the heat and gives heat. ठीक है? So we don't want to give. So you remove the HME filter from the circuit. HME filter देखा है ना तुमने? वो circuit से बाहर निकालना है. So that you have cold air moving up and down. Clear? Then you have something called as rhino chill. It's another active. What is rhino chill? Nasal. There's a mechanism like the HFNC. Similarly, there was a device because that time hypothermia was so big that we wanted to get down the brain temperature as quickly as possible. So they used to put something called rhino chill. That means they put in like an HFNC and that will give very cold air inside and cool down the brain on top. That's rhino chill. Okay. Then you have Arctic Sun. Have you heard of Arctic Sun? Arctic Sun was a device we used to deal for almost 1-2 years. We used to deal. So you put big pads all across. It looks like some sci-fi movie. पूरा pad blue color का pads रहता है पूरा ऊपर से नीचे पूरा यहाँ पूरा around white पूरा blue ऐसा. And then with a button you can change the temperature. Temperature changes immediately. Core temperature. Arctic Sun. It's called Arctic Sun. Expensive था, but we used it for many patients because at one stage we were also looking at hypothermia for cardiac arrest. Okay, now that has also gone down. So we used to do cardiac arrest. So when you use hypothermia cardiac arrest, active cooling के लिए we used to use Arctic Sun. So we had this device here for quite some time. We had that device for quite some time. We used it. It's simple. You can just press a button and the temperature comes to whatever temperature you want very quickly. Within 5-7 minutes it becomes like that. It chills the whole body and then regulates it. मतलब it is an auto regulatory cycle. वो टेम्परेचर देखता है और उस हिसाब से वो चेंज करता रहता है. वो पेशेंट कभी भी टेम्परेचर ऊपर जाता ही नहीं उससे. हम लोग कभी क्यों नहीं यूज करते हैं वो? It's very expensive. It's easier to be vigilant rather than do passive cooling. समझ में है? Active cooling. Clear on this? So it's other. Then the last thing comes is evaporative loss. Evaporative and radiative loss. Evaporative and radiative loss. When I say radiative loss means my temperature around is cold. That is temperature around is cold. So that is why there is evaporative loss. Radiative loss. When I say evaporative loss means there's a fan. There's a fan. So that is pushing the hot air from the body out. It's pushing it out. So you put the fan not this side. In our ICU, you put the fan on that side. So that the air goes out. The air doesn't remain there. So the fan, when you're putting for a patient who is for hypothermia, you put the fan on that side. Okay, so it pushes the air outside. Okay, conductive cooling, evaporative cooling, radiative cooling, and intravascular cooling. These are the various types of coolings you have. Conductive. Of course, we are not going to use any of these. We are only going to use intravascular, our drug paracetamol, and maybe you can use a fan. But you should not be in that territory where you're using a fan for a raised ICP. It बहुत ज़्यादा हो गया वो. ठीक है, you should not be able to use that fan and all because you have to catch it before that. Clear? So that's why it doesn't come here. So where do I use this? अभी तक हमने बोला normothermia. So where do I use it? So there are conditions somewhere here where whatever I'm doing, the ICP is refractory. I don't have the time to get that decompression done. वो decompression के लिए मेरा surgeon नहीं है. My decompression surgeon is not there. He's going to take some time to come, or he's involved in some other case. Okay, at that time, somehow I have to reduce it. My barbiturate is not available. My propofol is causing huge hypotension. And hypotension itself will drop my CPP, cerebral perfusion pressure. So I am in a situation where my therapies are not working. Okay, so when my therapies are not working, I will want to use hypothermia. That's why it's a plus or minus, not included in the tariffs. Okay, it's a plus or minus. That's why it's not included in the tariffs. समझ में आ रहा है? So if I am in a situation where I can't use barbiturates, can't decompress, I am in a situation profile not working that well, and I need to still reduce the ICP, I will resort to hypothermia and take the risk of that infection. Because not doing it means patient is going to die. Because not doing it at that time means patient is going to die. Otherwise, we have not put it as a part of the tier management. Sometimes it's not put as a part of the tier management because the risk is high. But here the benefits become higher when you're in that situation where there is nothing you can offer. You can offer anything beyond that. That's why it comes to hypothermia there. You understand? So